Well, good morning, folks. Wanted to just first make sure that we have audio and it looks like I have a ghastly pale going on with my face on the video portion of this. So hopefully we'll get the slides up and you won't have to look at that. But are you able to hear me okay?
Yep, I can hear you fine.
Wonderful. Thanks. Thanks, Susan. Okay, I'm going to see if I can get the slides up now. Hey, David. Okay. All right, I think we can go ahead and move toward getting started here. Just to verify that people can hear and they can see slides and that the slides are moving. Does that all seem to be okay for folks?
You're good on all fronts.
Great. Thank you very much. Well, welcome. And for those of you that have had to travel this morning, thank you for braving the roads and the weather. And hopefully we'll be getting close to enough of this. But it is what it is. We're Michiganders and we're prepared for this sort of thing. So welcome to our lecture series and part 2 of our hospice eligibility and regulatory series. So we're going to go ahead and dive right in. Last week, we talked about some of the basic issues that hospice physicians need to be aware. We're going to take a deeper dive today and look at a number of different regulatory issues. And specifically, this is really designed for fellows, but I think it's a good review also of what really a hospice medical director is supposed to do and what are the things that you need to know. And these are not only from a practical perspective. I had mentioned last week, even those of you who are planning a career in the palliative realm need to know this stuff, because the patients, many patients who you serve within the hospital or the clinic setting will one day be finding themselves within the hospice world. So we're going to talk about the medical director position. We're going to talk about very specific admission and certification regulations, recertification. One of the trickier areas can be relatedness of therapies, and we're going to talk about discharge processes. I'm not sure we'll get into audits, but we may if we have enough time. So, again, conditions of participation we talked about last week, and just once again to acknowledge and thank Mike Raffleson for the initial accumulation of these slides. But the conditions of participation that's the rule book, which really governs what it is that hospices do, and specifically that we as medical directors must understand. I just wanted to acknowledge, first of all, that hospice work is not all rules and regulations. I've worked in this field at some level for 40 years. It's not all rules and regulations. It's tremendously rewarding. It's challenging medicine. We work with wonderful teams of committed professionals. Some of the best working relationships I've had have been within professionally throughout my years have been within the hospice realm. Also, we're caring for people at the greatest time of need. They're very vulnerable, they're very trusting, and we have an opportunity to meet them at this point in their lives. The appreciation, the gratitude that you receive from the patients, and particularly the families, is heartwarming, and it frankly carries us during those days when things seem to be bogged down in regulations, or we find ourselves frustrated with recalcitrant families. You do good work, and it's really appreciated. Generally speaking, for us as physicians, the lifestyle and remuneration is pretty good. It's also technical and challenging science. This is not just sitting by the bedside holding hands and pushing morphine. This uses our knowledge of pathology, anatomy, physiology, pharmacology, and psychology all blended together. So for the fellows in particular, you're picking a field that really checks a lot of boxes in terms of why people choose to go into medicine in the first place. So let's get into the nuts and bolts of it. First of all, the role of the hospice medical director. We are primarily, as medical directors, responsible for the provision of services under the hospice benefit. There are 2 paths for certification for people that want to be board certified in this specialty. The one is the more, I think, commonly known Board of Medical Specialty certification, as granted through the American Board of Medical Specialties, and your participation in fellowship program and successful completion allows you to sit for that board and to be certified in this specialty as other medical subspecialties. There's also what's known as the Hospice Medical Director Certification Board. And that was created a decade or more ago. And really the intent of that was to recognize the unique skill and talent of physicians who serve as hospice medical directors. it also had a unique niche because it does not have the same requirements for fellowship training as the traditional medical subspecialty does. And so those, there are hundreds, if not thousands of doctors throughout the country who have been great hospice doctors, but they missed the grandfathering window and did not complete fellowship training. And this is an opportunity for them to be recognized for the expertise that they have in the field. And if you have any questions about that, you can check our Academy website. Is the organization that the American Academy of Hospice and Palliative Medicine that launched this specific and independent board. So there are multiple roles of the hospice medical director, and I've just put some up here, half a dozen of them, as a hospice physician, as a hospice and palliative physician, as a chief medical officer, as an inpatient hospice physician, as an administrative medical director, as a VP of medical services. And they all have a little bit different shade to them. They all have different roles and responsibilities. At one point or another over the last multiple years, I've served those roles. And in many circumstances, we as hospice physicians and medical directors serve multiple roles at the same time. A lot of times that's because of the need for that type of skill and talent and the lack of available bodies. Sometimes it's just because the size of the organization does not require multiple administrative roles. They can be shared by one person. But you'll be exposed to those different roles. Specifically, the hospice medical director. A hospice can only have one hospice medical director per provider number. I don't want to get too technical on that, but when a hospice goes into business, they get a Medicare provider number, and they are allowed one medical director per provider number, even if there are multiple locations for that hospice, and even if it's a huge census. We've had censuses of hospices that well over 1,000 with multiple locations, but they operate under the single provider number. And in that particular case, they can only have one medical director. Now, the medical director can have a physician designee to serve as the medical director in the absence of the medical director. And certainly other physicians can be employed or under contract with the hospice, but they cannot be called the medical director. And when you have additional physicians on the staff, there must be an organization chart somewhere in the confines of that organization that shows that the physicians report to the medical director. So those are just some of the technical aspects of the regulations that they put in there. Only one medical director. You could have other doctors, but they have to report to the medical director. Their duties, clinical leadership, of course. We are the experts in terms of the symptom management and of these patients. And so we provide that leadership to our other physician colleagues in our organization, as well as to the nursing and social work staff. Medical expertise along with that. Technically, if you look at the regs, the medical director has a role in leading the interdisciplinary group team meeting, our interdisciplinary team meetings. In practice, it typically doesn't work that way. Usually it is a nurse manager or someone of that nature who leads the meetings, but the physicians must be present and they must contribute to that. And they are ultimately, again, responsible for the medical care. I think that we have an important opportunity to facilitate a culture of collaboration. And that's an important part of what we do. I think that our role, especially for the good of the patients, the community, and our organizations, we must build relationships with referring PCPs, community specialists. So it's not just about seeing patients. It's not just about certifications, but about developing relationships that allow our community and our medical community to understand and appreciate who we are and how we want to serve this community. Identify opportunities to improve care delivery, use resources effectively. So we want to put those hats on, those QI hats. And of course, to ensure compliance with legal, regulatory, and clinical policies and procedures. And in order to ensure that, you need to know them. So those are the sorts of things that in your fellowship training, as you sit in on the team meetings, as you work within the context of your hospice organizations, that you will become more and more acquainted with those. Now, specific with rules and regulations, I want to pick out just a few that are relevant. And one is the patient choice of attending. That's a concept in hospice in which the patient has the responsibility, the right and the responsibility of choosing an attending physician. And they get to choose whoever they want. Many times it's a PCP. Often it's the most recent specialist who was responsible for managing their hospice diagnosis. So it might be the cardiologist, it might be the oncologist. It really truly can be anybody. I've had some, I would say, a little bit awkward circumstances in which someone out of state who knows me wants me listed as their primary attending physician for their hospice admission in Iowa. And I tell them I'm not licensed in Iowa. I'm happy to be to kibitz from the sidelines, but I can't really serve because I'm not licensed. So there are some limitations, but it just, the patient gets to choose. And you may find that if you've been their palliative physician within a clinic setting, they may want to choose you to manage their hospice care, even if it's not the hospice that you normally affiliate with. The regulations state it like this: the attending physician is the doctor of medicine or osteopathy or an NP who is identified by the patient at the time of election of the hospice benefit as having the most significant role in the determination and delivery of his or her medical care. That's the person they're going to call when you're in pain. That's the person that's going to be signing relevant documents. And this is something that's important to know because I've seen this. The hospice cannot arbitrarily assign an attending. You can't tell the patient, well, we normally just assign you our medical director as as your attending for this purpose. Now, you can certainly offer the hospice medical director, and you can even say, you have the right to choose. You can choose whoever you want. What we find is that many people want their particular physicians involved, and that's perfectly fine. And there's also a process by which, for example, your PCP may be who you want to be your designated attending. PCP may say, I'm happy to do that, but I don't know opioid dosing and conversions and things like that. So I really want the medical director to be the first call for those types of things. So there are different ways that you can honor the patient's choice and still maintain the integrity of the medical director relationship with that patient. The hospice medical director certainly can be offered as a choice if no other physician is available or if the patient requests a hospice medical director. In the initial paperwork, there is a written request and form, and it must be submitted and signed by the patient for the medical who they're selecting as their attending. And if anytime there's a change in the attending, they have to sign that. That's an important part of the rules. Now NPs can be an attending that varies from state to state. They are able to see any hospice patient, but they can only submit billing for patients for which they are the attending of record. That's what the AOR is, the attending of record. And physicians can bill all billable visits regardless of attending status. So if I'm not the attending, but the patient is paying prices, I go out, I can bill that visit. If the patient selects me as the attending, I can go out and pay a visit to that patient and bill that visit. I cannot bill an administrative visit. So if I'm doing that just to determine eligibility, or I'm doing that, as we talked last week about the face-to-face, I think we talked about face-to-face last week, I cannot bill that visit for a strictly administrative purpose. Now, admission process. After eligibility is determined, 2 physicians must certify the terminal illness no earlier than 15 days prior to election of the benefit. I've seen a lot of the circumstances of what is called technical denials, in which the Medicare administrative contractor will decline an admission because the certification was signed outside of that window. A verbal certification is acceptable. However, the hospice cannot bill for that patient's care until the verbal cert has been signed and the narrative has been completed. these are really important technical aspects that you have to do, whether you like it or not. If the hospice wants to be able to bill for the services, you got to do those. Generally, the two physicians are the hospice medical director and the community attending physician. If there's no attending, and that might be if it's urgent or emergent, or if the patient elects the hospice medical director as the attending of record, then that doctor can sign for both as both the attending and the medical director. They can sign both places on that form. Narratives have become really, really important. And the reason they're important is because for hospices that are getting caught up in targeted medical reviews, other sorts of audit tools that the government uses, a lot of what they're pulling and their AI generators pull from the physician narrative to look for specific things that are or are not there as a first line of making those determinations whether this hospice needs to be investigated. So it is a brief description of the clinical findings that support a life expectancy of 6 months or less. I had this slide last week, but you paint the picture of a 6-month trajectory that disease runs its normal course. So certainly you're going to have the diagnosis, the functional status, and if you're going to use decline, make sure you're defining the decline, what they could do 3, 4, 6 months ago, what they no longer can do now. That gives a very clear picture of what that decline is and over what period of time. What their nutritional status is. If they're cachectic and emaciated, talk about that. If they've lost weight, how much weight over what period of time. And it's really important for you to indicate where that came from. Just say patients lost a lot of weight over the last year. That means nothing. To say that the patient has lost 16 pounds over the last 3 months from 176 now down to 160. That's meaningful and use that kind of detail if it's available. Excuse me. So diagnosis, the functional status, decline, nutritional status, whatever lab values you have that are supportive. And we talked a little bit about that last week when we were talking about the LCDs. But the lab values, any symptoms, infections, if they've had falls, especially injurious falls, behavioral changes, all of these are relevant pieces to help us understand the changes that might be going on in the life of this patient that suggests to us that the prognosis is limited. I would say less helpful, but are very valid. What kind of psychosocial changes have occurred within the patient's life? What kind of medication changes have? Sometimes those medication changes can reflect some very significant underlying medical issues. So whatever it takes to paint the picture is what you do. Now, the rules for the narratives are pretty straightforward. You can't use boilerplate language, and you can't check boxes. It has to be a true narrative. And if I could, from some of the reviews that I've done over the years of hospices that were in trouble, one of the biggest challenges that I see is when physicians cut and paste their narratives from certification to recertification to recertification. I will tell you that those are going to be denied more often than not. You have to be novel in each, not write a novel, but you have to be novel with each one. For example, I will see something that will say, patient has lost 30 pounds from 180 to 150 over the last 4 months. And that appears for 6 certification periods in a row. Okay, someone's cutting and pasting, is not paying attention. There's no validation in that particular note. So it can't be boilerplate. It has to be legible if you're still in the process of writing. Date and signature must be in the physician's handwriting and legible. Now, there are some accommodations now for electronic medical records, but there has to be an official signature, whether it be written or now electronic. The attestation is different than the narrative, and it must be present, and it must follow the narrative, and it must precede the signature and date. I know that sounds pretty nitpicky, but I will tell you that regulators, they like nitpicking. And so again, the digital signatures and dates are allowed if they follow the rules above. So you have the attestation, which is your narrative. I'm sorry, you have the narrative, you have the attestation, and I'll give you an example of what that is in just a moment. That can be boilerplate, the attestation, because it's just affirming that you composed that and that represents what you believe, but it has to be signed as well. So this is an example of a narrative that I like. Parent is a 42-year-old man admitted with a diagnosis of pancreatic cancer. Cancer diagnosed in October of 2015, found to be metastatic to the liver and stomach. PPS is 60% down from 80% 6 months ago. He has completed chemotherapy, has demonstrated disease progression, and is no longer a candidate for cancer-directed therapy, has poor appetite, continued weight loss, and I believe his prognosis is less than 6 months if the disease progresses on its expected course after review of the record and admission nursing notes. You don't have to see the patient, but the note suggests that you're very familiar with this patient. Now, in just a few sentences, we have a very clear description. Probably the one thing I don't like about that note, and it may be that we don't have the data, but it would have been nice to have how much weight loss, continued weight loss, would have been nice. But there's no question in when you read this narrative, this patient has a prognosis of metastatic pancreatic cancer, disease progression despite treatment. He's going to die. So we get that. And this is what the attestation then looks like after the narrative. Based on these findings, it is my clinical judgment that this patient's prognosis is a life expectancy of 6 months or less if the disease runs its normal course. Important to have that part in there, by the way. By signing my signature, I attest that I compose the above narrative based on my review of the medical record, or, if applicable, my examination of the patient. And in most circumstances, it's the former and not the latter. Then there's a signature, the printed name, and the date. So that's how that works. Narrative, attestation, signatures. I was working on for an attorney helping a hospice that was having some problems. And I was looking at one particular file. Whoops. Oh, shoot. It didn't get into this slide deck. I'm going to read it to you because it's just one sentence. And to me, it was a great example of what not to do. Okay. This was the entirety of the initial certification: senile degeneration and CHF, fast 7D, declining. That's it. I can't tell anything. I don't know how old the patient is, don't know how long they've been sick. What does declining mean? The only thing about that, they're fast 7D. So that gives me some picture of what the patient's clinical status is, but nothing else. I told, the hospice there, I can't defend this admission on the basis of that CTI. Patient may well have been eligible, but you can't tell from that. And that's going to result in denial every time. Now, in order to defend that, then you have to go in and extract from the remaining pieces of the chart, the nursing notes and such, what's going on, and figure that out. So after your initial certification, there are recertification periods. This almost always is a board question in terms of recertification periods. Your election benefit periods, the first is a 90-day period, 3 months. The second is a 90-day period, another 3 months. And from the third and subsequent benefit period, they are 90 days. And there is an unlimited number of 60-day benefit periods for recertification that is available to the patient. Wasn't always that way. In the early days, there was a pretty hard and fast stop. In their wisdom, they recognized that not everybody follows the same rule. They didn't read the textbook on prognosis and how their disease should progress. And so they may live longer. But you have the responsibility as the medical director at the beginning of each of those recertification periods to provide a short paragraph explaining why that patient remains eligible for hospice services. Now, this is just a little side note, but just so you're aware, and I'll explain why this came into being. The payment of everyone, I think, is aware that hospice payment is by Medicare is a per diem payment. The hospice receives a set amount every day that the patient is under service. It's not the same though throughout the course of the admission. So the set payment is higher for the first 60 days. It's reduced from day 61 on through the rest of the hospital or through the hospice admission. And retroactively, they bump it up for the last 7 days of service. And this was really put into place because anytime you make money available, someone's going to try to figure out how to game the system. And that's happened in hospice, in which there are some bad actors out there that are trying to figure out how can I get money without really providing the service. And they focused on what I refer to as kind of low-cost patients. These are folks that typically have some sort of dementing illness, are in nursing homes. There's not a lot of work that the hospice has to do with the patient, depending upon their status. Still, they need to attend to them, provide their medical care, provide the medications if necessary, and all the things that we would do as hospice. But it's certainly much different than, a younger person that is at home, has a metastatic cancer, and has a plethora of symptoms that have to be managed along with that. And so certain hospice organizations found that was kind of a nice well to dip into. They could sign on a lot of patients with dementia in nursing homes and collect that money. And the government said, well, really, once patients are in hospice and they've kind of hit a smooth plan of care that seems to be working well for them, we don't need to pay the hospice as much. That the biggest costs for hospice are at the beginning and at the end. So they revised this U-shaped curve of reimbursement to meet that. Now, if a patient discontinues or leaves the hospice benefit for any reason, they have forfeited the remaining days of their current certification period. So, for example, someone comes into hospice, they had a stroke, and they look like they're not going to survive. So the hospice is brought in, they sign them up, they send them home. But goodness, after the first 3 weeks, they became more alert. They started eating. They were aphasic and hemiparetic, but medically seemed to be stable. They were eating, gaining weight, developing some communication tools. And after about a month, you say, wow, I don't think they're eligible for hospice services anymore. And they're discharged. But at some point down the line, when they're readmitted to hospice, they've already served their first eligibility period, no matter how long it was. If it was a week, if it was a month, whether it was a full 3 months. When they are readmitted back into hospice services, they would come in under the second benefit period, no matter how long the first one was. And likewise, you might have long stay patients. They've been in hospice for 6, 8, 10 months. And were medically deemed to be no longer terminal and discharged. Their next benefit period, when they're readmitted at some point down the line, it doesn't restart, it continues on. So if they were discharged in the midst of their 9th benefit period, their admission will be in the 10th benefit period. It's pretty straightforward. Now, the face-to-face, it came into play about a decade ago. And that is really a critical component of the recertification process for patients who are entering their 3rd or later cert. And every recertification period needs a face-to-face. And that can be performed by the hospice physician or nurse practitioner and must have that face-to-face encounter no more than 30 days prior to the recertification date. I think the convention with many hospices is to hire nurse practitioners to do that. And that's kind of an economic issue. Nurse practitioners don't command the salaries that physicians do, and they are non-billable visits. And so to put that in the hands of a competent nurse practitioner is great. And I've just seen some, I can tell you, having done a lot of recertifications, looking at the face-to-face visit from the nurse practitioner can be quite valuable if they're trained in terms of the data that needs to be present to help to validate that. Now, the purpose was to enable hospices to comply with eligibility requirements and identify and discharge patients who do not meet criteria. The sense that the government was thinking was that all these long stay patients, if the physician or someone laid eyes on them other than just the hospice nurse, we would recognize that they perhaps are no longer eligible. And that's why that was put into place. Face-to-face visits, as I mentioned, these are regulatory non-billable visits and must be done by the physician or NP. They must be employees of the hospice and not contractual. Now, you can bill a separate billable visit if a billable service is also provided at the time of the face-to-face. I mentioned this last week. I just wanted to reemphasize that. By the physician or the nurse practitioner who's also the attending of record. So if someone is due to a face-to-face, but there also needs some review of their medication list, if there's a problematic symptom and it's within that 30 days of the recertification, by all means, you can bill the visit, but you need to have also acknowledgement. So the documentation provides the documentation for the billable sort of that. There's also a documentation for the face-to-face for recertification visit. And if you separate those, it makes it much cleaner and much easier to justify both billing for the visit as well as for the regulators who may be wanting to look at the face-to-face encounter. Now, discharge revocation of the benefit. There are reasons to discharge patients. The one most commonly that we see is that the patient is no longer judged to be terminally ill. I gave you one example of a stroke patient who inexplicably improves. One of the more common ones that we see are in the non-cancer diagnoses, in which they come in, for example, Alzheimer's disease with a relevant comorbid condition, let's say aspiration pneumonia and stage 4 decubitus wound. And over a period of months, the pneumonia has resolved and no further episodes of aspiration. The wound heals, and now you have someone with advanced dementia but no comorbid conditions. And so they're judged no longer to meet that criteria. And so you can discharge them at that particular point in time. One of the things is that it should never be last minute. And I think that it's sometimes problematic if you happen to discharge someone on the last day of a benefit period. I will tell you the regulators interpret that as being they should have been discharged earlier, but you are just hanging on, squeezing a few more days of per diem benefit out of the government when you intended on discharging them all along. And you didn't, and you knew you couldn't legitimately recertify them. I would avoid those. I would discharge the patient as soon as you determine that they're no longer eligible for hospice services. I was reviewing a file once for a hospice, and one of the strong justifications that really helped us in terms of winning that case was the finding that as soon as the hospice determined that the patient was no longer eligible, they stopped billing on that day. And they continued to care for the patient until the safe and appropriate discharge transitions could be made. So they might be in service for another few days or 2 or 3 weeks, but not receiving the benefit because they had determined that that they were no longer eligible for service, and ethically they felt that they could not bill for those days. Now, I would say that's the rarity. Most people will bill as long as they're in service, but there needs to be discussion, disease plateau. Discharge should occur prior to the notice of the discharge. And this is a result of an evaluation over time. And so a lot of times these are on the horizon. You see someone who just doesn't seem to be declining. And, you know, I've defended a lot of cases in which we have seen what I would tell, except they had the decline that we expected. They just lingered longer than what we physiologically would have anticipated. By every right, we would have expected that had the disease run its normal course, they would have died sooner. It didn't run the normal course. That's not our fault. That's not the patient's fault. It's just the way that it happened to be for this particular circumstance. So you can justify long stay patients, but again, each eligibility period needs to demonstrate the changes that are consistent with hospice eligibility, or a clinical scenario consistent with hospice eligibility. You know, other examples that I've had are patients with widely metastatic progressive cancers who we expected to die within months, and it took a couple of years. At every day you visited them, you could determine, because of their diagnosis alone, as well as their medical clinical status, that if it runs its normal course, it should be, they're still eligible. And most of those are going to be just fine. Again, it really depends on your documentation. Any questions? I'm going to keep going on, but please feel to interrupt if anyone has any questions.
John?
Yeah.
Ken Hansen. Hey, so is there timing in terms of enrollment and starting of treatment and doing the certification? In other words, patient gets enrolled, I don't know, Friday night, and there's a glitch in the system, and the CTI doesn't get done until whenever. Am I making myself clear?
Well, I think that what you're asking is two things. They can't provide care until the certification is obtained.
Right. That's true. Okay.
Okay. And
Yep.
it can be a verbal certification, so that's okay. And I understand there are hiccups and glitches, but I would think that it should be almost a rarity that someone is coming into hospice. You've got the nurse who is at the bedside doing the workup, doing the admission workup, and can't find any physician anywhere to provide a verbal certification. Once a verbal certification is provided, then you can initiate care. They cannot bill for that service until there is both an attestation, the narrative of the attestation, and the signature. You can't bill for that visit.
Okay, that makes sense. Thanks.
Okay. So a discharge for extended prognosis is the most common we see, but there are others. They move out of the service area. That seems to be a fairly obvious one. They move permanently away. And one that we see fairly frequently, they may enter a facility without a contractual arrangement with the hospice. So for example, if a patient is in a skilled nursing facility, that skilled nursing facility is allowed to limit the number of contracts that it signs with hospices. And if your patient happens to go into a facility with which your hospice does not have a contract, then that patient would need to be discharged and put under the care of the hospice that has a contract with that facility. There are sometimes in circumstances, and I mean that happens fairly regularly. I mean, for example, Holland Home, we have 2 large campuses, skilled nursing facilities. We obviously have a hospice as well. So our Faith Hospice is contracted with our facilities to provide hospice services. But we've had circumstances in which one of our residents may have a daughter that is a nurse with another hospice organization with whom we don't normally have a contract, but we would execute the contract to allow that hospice to care for this particular individual. So you can do one-off contracts with the nursing homes. It depends on the circumstance. Vacation, if someone is going to be, under care here and they want to go down to Florida for a month, there are circumstances under which you can have a relationship with that hospice that's in the service area where this patient will be vacationing. So if there are emergencies and things like that, there is an available resource. However, sometimes people will go to areas where we can't have they're not eligible for a service contract, and so the patients need to be discharged and then readmitted once they return home. Discharge for cause, always a last resort, and you have to be kind of careful about that because if someone is discharged and they don't agree with that discharge, they can appeal the discharge. And I've seen circumstances in which really challenging, in which a hospice has determined that someone is no longer eligible on the basis of prognosis, and they discharge the patient, and they appeal, and the appeal board says, "Yep, this was wrong. The patient should continue in hospice services, but you as a hospice have determined they're not eligible for services." So you get into some really strange areas like that. The for cause part that I see most commonly have to do with safety issues for staff, where they are threatened, where it is a physically unsafe environment because of the presence of illicit drugs, specific activities going on in the house, firearm threatening, things of that sort. And so if it is patently unsafe for your staff, then discharge for cause is not unreasonable. Revocation is a little different than discharge. So discharge is motivated by the hospice. Revocation is motivated by the patient. And the patient or representative can revoke the hospice benefit at any time for any reason. They can decide they just don't want that person in their home, and they can revoke hospice. And it has to be in writing. No verbal revocations are allowed. So someone has to come out and the patient or the DPOA has to sign the revocation. It cannot be backdated. I can't say, we want you out as of yesterday. It has to be that day or forward. Now, the patient also, if eligible, could still reelect hospice benefit at any point in time. But as we discussed earlier, that would be starting with the next certification period. Now, I think this is an important. You as a hospice cannot revoke a patient, and you can't insist that a patient revoke. Again, this language is important. The concept is also important. And usually there is some question relative to discharge and revocation on the boards. So you can't revoke the patient. Or tell someone you have to, if you want to receive that MRI, you have to revoke hospice. You can't do that. If you make a determination that the patient family are no longer can have a value system consistent with the hospice plan of care, and they are seeking care which potentially could be extending the prognosis, then you're allowed to discharge them, but you can't tell them to revoke. That's an important point. Okay, I want to spend a little time on relatedness. And relatedness is important because according to the rules and regulations, anything that is related to the patient's terminal illness is going to be financially covered, paid for by the hospice. And you have to make that determination whether something is related or unrelated. And some of the kind of the famous ones are, hypothyroidism. If hypothyroidism has no relationship to the patient's terminal illness, do I need to pay for their Synthroid? And the answer is no, you don't have to if you have made a determination that it's unrelated. So you have to make a determination there. For purposes of my analysis of terminality, I look at all the diagnoses and I will make a determination. Does the presence of that particular medical condition make it likely that their decline and trajectory is going to be accelerated? So someone who has diabetes that is uncontrolled, someone who has type 2 diabetes that has been stable for 20 years, and they now enter with stage 4 metastatic lung cancer. That diabetes may not necessarily impact their trajectory. However, if they're coming in with end-stage heart failure, they have diabetes and are insulin dependent, and they choose not to get blood sugar checks and not to get their insulin, and their sugars are running in the 500s and 600s, that probably is going to have an impact on their trajectory and would be included as a relevant comorbid condition that is impacting their terminal trajectory. And should they then need some element of care for that, then that would be covered as a related item. So whether it's related determines on who pays, whether the hospice pays, whether Part D pays, or whether the patient pays. And so we had a great lecture a couple of weeks ago with Dr. Marilyn McPherson. If you were not part of that, I would recommend you go to the YouTube channel and check it out, because she talks a lot about strategies for deprescribing. And that is one of the physician's most important processes within a hospice admission, is to determine which of these medications are still relevant and important for the patient to continue to take. And should we be deprescribing or change? There needs to be an evaluation of the treatment plan and goals of care. someone for whom, and again, Dr. McPherson touched on this, for whom, they're in the cholesterol medicine. Do they still need that? How you have those conversations is important. Coordination of their specialties. When you've got someone who has been on an oral chemotherapeutic agent, is that still necessary? Does that still provide any benefit? You probably should have a conversation with the oncologist about that to get some backup, if it were, so that when you talk to the patient about discontinuing, there's a rationale for doing that. Relatedness is important because of the money issue. If you have someone for whom their renal failure is a contributing portion of their terminality, and they're on dialysis, and you've determined that it's a related thing, you're paying for the dialysis. So there are some financial considerations also. I'm going to skip that; it's too busy. But it's a nice algorithm. And if you want to later pull the PowerPoint from the YouTube channel, you can study that and blow it up in more detail. But it's a nice algorithm about, is this related or is this not related, and who pays? But it really kind of follows a lot of the rules that I just outlined there. Key points of relatedness. It really determines what will be covered by the hospice benefit. And therapies can be either related or unrelated. And that's really your determination. Is it related or unrelated? So if related, you may have something that is related to the terminal illness, but is no longer necessary. Someone who comes in with end-stage congestive heart failure, and they're now their blood pressure is running high, and you want to maintain their antihypertensives, and they're on their cholesterol lowering medication. You don't think that's necessary anymore. That's related but unnecessary. So anytime patients are on something that they're going to continue that is not part of the benefit, it's called an ABM, which is the advanced beneficiary notice of non-payment. That has to be written out, and that has to be provided to the patient to say, we're not covering this, and this is why. And that if they want to continue it, that they'll be responsible for it, but the hospice is not going to cover it. I would say in the vast majority of circumstances, if you have the conversation with the patient and why it's not needed anymore, you typically are not going to have a ton of pushback from the patients. But every once in a while, you get someone who is, they're end-stage dementia, they're fast 7E, 7F, and you have a family member that insists that they stay on their dementia medications. They're clearly not necessary, but they are related. You provide the ABN and have a conversation with the family about why they're no longer necessary. What the government really expects is that virtually everything that the patient is on is somehow going to be related, and therefore the responsibility of the hospice to cover. That's why this process of the ABNs were developed, so that if you surely and truly are not going to cover it, we want you to put it in writing why you're not, and make sure that the patient sees that. So relatedness is temporal. It may be initially determined at admission. It may change its course. It may need to be updated throughout the patient's course. So when someone is admitted and you have a list of related conditions or comorbid conditions, as life changes, as things change, something might else enter into their realm, which is now related that wasn't there before, something that previously was related, you may determine is no longer related. And that fluidity certainly can exist. I would make sure you document that well, especially in the context of your narratives. As you're well aware, the IDG has to develop a plan of care report on each patient every 2 weeks. And so those are the sorts of things that would be discussed within the team meeting and documented in that document. So we got a couple minutes left, so we'll talk a little bit about the adjudication process. If you are denied a payment, the level one a process of appeal is what's called a redetermination, and that's done by your local payer source. So they've denied your payment. You can go back to them and say, hey, wait a minute. Here's some additional documentation, or here's a narrative that you didn't see, or here's why we think this should be paid. And they may make a determination, oh, we didn't understand that. Now that we know that that's what it is, we'll pay. I got to tell you, in most circumstances, those redeterminations, they still deny them. So, so then that's the level 2 denial is called a reconsideration, and that's done by a quality contractor, which is independent of the MAC. So they take all that information and then they make a determination. Yeah, the MAC was wrong. They should have okayed this, and it's okay. We'll allow that claim to be paid. But in a lot of circumstances, they just simply follow the MAC and say, no, that shouldn't be paid. Now that takes it then to the administrative law judge hearing, in which you are able to present your case to an administrative law judge, who generally, I will tell you, generally are sympathetic to the hospices, especially if you've created a logical visual scenario so that when you're in front of the judge, and these days, ever since COVID, most of these have been telephonic. It's not even videos, just by telephone. So you can structure your narrative. Here's what's going on. So that the patient, so that the judge can visually see what's going on with that patient and why hospice eligibility was necessary. The hospices, by and large, are successful in an ALJ hearing. There are two other things that I've never been involved in the Medicare Appeals Council, because quite frankly, if I can't make the case through the first 3 levels of eligibility, it may not necessarily be that strong a case in the first place. But you can go to an appeals council, and ultimately you can go to district court if you want. Where I've seen that happen are when you've had patients who have been long stay patients, tens and tens of thousands of dollars at stake, or hundreds of thousands of dollars at stake, and their entire admission has been denied. And so sometimes you need to get more involved with that kind of review. So a few websites. NHPCO is now called the Alliance for Care at Home. You can still get there for the NHPCO website, but I'll need to update that. It has some great resources. There are regulatory updates and review courses, and I've listed a couple there that you can again pull out of the PowerPoint. Hospice Medical Director Certification Exam resources. So I mentioned earlier that is a board that requires you to sit for an exam, and that board offers resources for hospice medical directors to access. And our academy, the American Academy of Hospice and Palliative Medicine, has a hospice medical director manual, which gets periodically updated, and that's a very, very good resource as well. What it looks like, and if you want a picture of the cover. So anyway, that's it. We got a couple of minutes before our case. If anyone has any particular questions, comments, concerns, curiosities at all.
So if you have like the case where someone has a heart failure as their terminal diagnosis, but they have a trip and fall, not caused by their heart failure, but they get a hip fracture that can lower their prognosis of 6 months based on mobility, maybe. Would you consider that just related and should be covered by the hospice, or?
Yeah, so in many circumstances, most falls, except in rare circumstances, are going to be considered to be related to the terminal illness. They're weak, they're in a weakened state, and may have nothing to do with their disease process. But what I have seen that in most circumstances, under regulatory scrutiny, they'll say, well, that's related clearly. And if you're going to say, no, that wasn't, and they discharge because they're going to go into the hospital, they're going to get the hip fixed, which, by the way, you don't have to discharge for that purpose, but some hospices will. When they come out, certainly that has a great impact on their trajectory. And that would be included, now it's CHF and status post hip fracture and ORIF. And so that creates a different impact on the trajectory.
Kind of a similar idea. If like a patient were to get like a UTI, for example,
Yes.
and that's not related to their primary diagnosis, if you're the one prescribing the antibiotic, is that something that's related, or would that be something that you have Medicare cover?
I would say that I can't remember the last time I did not cover an infection.
Okay.
You know, our goal is to make sure that we provide all the resources to assure the patient's comfort. And in this particular case, the infection is interfering with their comfort. So yes, I would provide a short course of antibiotic and move on. And some people will, some people won't. You know, they develop, let's say, a pneumonia. Do you provide antibiotics for that? Kind of depends on the goals of care and if that can improve their quality of life or not. But if you're providing it, it should be covered.
Kind of a follow-up to my question. If you have an injury that you don't think your hospice is offering just pain management as an alternative to like surgical repair or consultation, would you have to provide that APN in that case if the patient wants to like go to the hospital and
The ADN is really intended for the ABM is intended for medications.
Oh, okay.
Okay. So, you know, if someone wants to go to the hospital, again, most hospices have contracts with the hospital to provide services for hospice or for the hospice related diagnoses. If it's not related to the hospice diagnosis, then Medicare would kick in for that.
Hey, John, Jay Becker here. Can you hear me?
Yeah, Jay.
Yeah, just to follow up on that, I think sometimes too that gets down to the questions of open access, and different hospices are going to have variations on how they approach that. I think both John and I have had very good fortune of working with community-based hospices that have probably been more on the open-ended. And so there's a lot more opportunity for discernment. Some hospices will be very tight in that. And so that can be kind of directed as much by your administration, board of directors, et cetera. But to John's point, I think our goal is to provide that safety net in the safest and most therapeutic and efficacious way possible.
Yeah, I think it's a good point, Jane. We're at the end, but I'm going to just one quick anecdote because it was years ago, I still remember it was the first inpatient palliative consultation down at Vanderbilt University. So this is probably 24 years ago or so. It was an older man in his upper 60s that had been diagnosed with pancreatic cancer 2 years earlier. So he's kind of already outlived his prognosis, but he's had recurrence. It is now providing a complete gastric outlet obstruction. So he has nausea, significant pain, and he's vomiting. And so they want to see what this newfangled thing called palliative would do for this patient. So I went in, had a conversation with the patient, his wife, one of their 7 kids. And this was in the fall, it was like mid-November. And looking at goals of care. Well, the other 6 kids were scattered around the globe in various ministerial pursuits and doing mission work and such. And they were all planning on gathering Christmas, and he would like to stay alive until Christmas. So I recommended that we start TPN and put in a decompression peg tube, which immediately relieved the symptoms, and the nutritional support helped to sustain him. I then referred him to hospice. And I was relatively new in the organization, and I got almost immediate call from the CFO saying, "What the heck are you doing here?" You know, because we're providing, you know, the kind of the equipment for suction and such for the decompression peg tube, and we're paying for TPN for this guy. And I said, it's consistent with the goals of care. It's providing, you know, his self-determined end-of-life closure goals, definitely related to his terminal illness. So yeah, we need to cover that. And so we did, and it was he had his kids all came home. They had a wonderful holiday together. And after the first year, he shut the TPM off himself. But he just said, "No, I don't want this anymore." And within about 2 weeks, he was dead. So So you just have to determine what is in the best interest of the patient. I would say that most pancreatic cancer patients would not get TPN. And certainly in my experience, that would, but there are times in which you have to take a look at those and cover those if it's consistent with the goals of care. Well, thank you all very much for your attention. And have a wonderful weekend. Hopefully we'll get some reprieve from the weather, and we'll see you all next week. For those for those that are staying on, Dr. Desai, do you have the case? Then I'll give you the seat of honor here. You need to bring up.
Nope.
Okay, great. Just to talk to us. All right, I love it.
All right, good morning, everyone. I wanted to bring up a case that, I got to be a part of when I had my time over at Metro. This case of a 68-year-old female. She came in with complaints of low back pain, abdominal pain, and left leg pain. She was found to have a sacral mass on initial imaging, and then on further imaging that was done, they found lesions in multiple areas concerning for metastatic disease, as well as a hyperdensity in her left femur, again, concern for metastatic to the bone in the left femur as well. As we got to talking, she had this really interesting kind of history of her medical care in the past. So she and her daughter in the past have had complaints of abdominal pain, and they decided to pursue care with a physician who practices alternative medicines down in St. Louis. Over there, that doctor had done a physical exam on her, done imaging. I don't know if he did imaging, actually, if he did lab work, and told her that all of her issues were because of a worm infection and started her on ivermectin. Her daughter in the past also had complaints of abdominal pain, found to be IBS, but he was treating her again with the ivermectin instead of any other medications to help her with her symptoms. And this patient was like, okay, the ivermectin's gonna take care of everything. It's gonna make me better. And that's what her goal ultimately is to get treated and to get better. So now when she comes into the hospital and she's found to, have metastatic disease, she's in denial about everything that's going on. She, again, is thinking this is all secondary to the worms that I was told that I had. Her doctor had taken a picture of her back, which she shared with us. And on that picture, honestly, it looked like just like an impression of like a wrinkle into her clothes. Like, when you sleep really good, you have like that wrinkle on your arm or your face from what you were sleeping on. And it honestly just looked like that. But that picture he used because it had a little curve to it to say that that was evidence of this worm infection. And, so obviously she has this whole belief that everything is related to worms. When we come in, we talk to her about how this is likely cancer, and that we're going to continue to do further testing to see what it's at. And what the primary is per what oncology wants to do. They want to do a breast biopsy to see if that's the source of the primary, if she did have a lump. With her not wanting to accept that this could be anything other than the worm infection, she initially was not wanting to do any further diagnostics to determine that. But, after talking with us, she ultimately decided that she would go through and get the breast biopsy to at least have another idea of what this all could be. And then, as we continued following course, she ended up not wanting to pursue that breast biopsy anymore because she was like, I don't know if this is going to change anything that I want to do. I want to keep following with this doctor in St. Louis. And continue with my care that way. Obviously, I wanted to take all judgment aside, and, do everything that's best for her. So if this is the course that she wanted to pursue, if we've talked to her about how this is likely cancer and, the testing is only going to likely confirm that. But if she wants to ultimately go to St. Louis, understanding the risks of, dying from not getting treatment for this cancer, then we have to, I guess we have to try to support her on that. But with her having this lesion in her bone on her femur, that was really extensive, that we were concerned for a pathological fracture, we tried to shift our focus to at least talk to her about getting that surgically stabilized before leaving. And so, she agreed with that. And then again, she, on continuous follow-ups, decided she didn't want to do that. So we kept supporting her, kept talking to her about, risks versus benefits, and she ultimately decided and did get it surgically fixed. While they went in and did that surgery, they also did do, a biopsy, and it determined that she had cancer. So now she had it on paper. It was confirmed that this is cancer. And, every day I would go in to check on her, she'd be like, hey, like, what are the results of that biopsy? Did you find anything out yet? It took a couple of days. And then when we ultimately found it out, she had it on paper. And then it came to the point of, again, talking about what she wants to do, knowing this definitive diagnosis. And she, we talked about chemotherapy. We talked about what oncology has to offer, after they already talked to her. And she told me that she knows chemotherapy is probably going to help her, but she has seen what chemotherapy has done to a lot of her best friends, her loved ones. She said it helped one person, but everyone else only had side effects or died, and she does not want to do it. At this point, I was like, okay, I feel like I've done my part in terms of telling her everything that I would recommend. But if, it's something that she doesn't want to pursue, even if it's something that I want to, encourage, I have to support her best in what she wants to do. And so, it was hard for me to kind of just be like, it's not the worms, it's cancer. Oncology does have options for you here, but, she wants to live. And if that's her ultimate goal, it just bothered me knowing that she didn't want to pursue the treatment, if that's what she wanted to do. So anyways, that was just an interesting case that I had, just trying to get through to a patient who had this idea in her mind that everything was related to one thing, and, but best trying to support her in having that life that she wants. She wants treatment, but she's not doing the right treatments, and just trying to navigate that. I want to see if anyone else, had a similar experience, or if you guys would like, what recommendations you guys would have to a situation like this.
All right, well, let's open it up to the floor. And so what do y'all think?
Harvey, you did such a good job with that family. Never being judgmental, never really telling her what she had to do. And we were very gentle with her when we gave her the diagnosis that her femur fracture was indeed her cancer. And I don't know if you remember or not, Porvy, we had 3 people in the hospital at the same time, all with stage 4 cancer, breast cancer, all being treated for worms.
Yeah.
And but her belief system was just like a religious belief system. She was so invested in it, and there was no breaking into it. And her family lived in the same denial, the same belief system. And interestingly enough, after she left the hospital, her St. Louis doctor transferred her to a homeopath in Phoenix, a homeopathic clinic, for her to have future follow-up.
So relative to the doc in St. Louis, I know that a lot of times people within the alternative field are physicians who have chosen to take up that level of specialty, but a lot of times they are doctors of something else and not medicine. Do we have any idea what that doctor was?
Yeah, so I actually Googled him. He was a medical direct, he had a medical degree. He was an MD.
Did anyone try to talk to him?
So I don't know if anyone did talk to him. I know the internal medicine team was thinking about either reaching out to him or doing something, but I didn't follow through on that.
No, they reached out. That's why she
Oh, they
got
did?
referred to Phoenix.
Yep.
Was his answer was he had taken her as far as he could, that she needed the next level of homeopathic treatment, which he couldn't provide in St. Louis. So the referral to Phoenix was from him.
Okay, so he was aware that she had a definitive diagnosis of cancer.
Yes.
Got it. Well, you're correct that we can't, when you talk about being, a mindset, a philosophy, I think you described it, Steve, as almost a religion. And there are those sorts of things that are propagated by, and Joel may have encountered some of this. I know that when I was doing ALS work a decade or so ago, we would have folks that would come in. There's a doc out of New Jersey who believes that ALS is not a real diagnosis, that it is just a consequence of Lyme disease. And therefore, if you treat with aggressive antibiotics and his proprietary line of supplements, that you can cure what people call ALS, but it's not really ALS. So obviously there are a lot of people who, get sucked into that, and they want to believe that, and they will invest to bankruptcy to try to hang on to that level of hope.
Yeah, and actually we have one patient right now who believes they have a form of, quote, healing ALS, where their most forms are deadly, but the one that they have might be one that reverts. And this is more work out of a doctor in Duke who kind of supports that theory as well. But Purvi, I wanted to also address kind of the moral distress that providers feel in this sort of situation too. We saw this a lot with the COVID pandemic, where people were denying COVID. They denied they had the diagnosis, wanted to live, but were not willing to undergo the treatments that we would recommend. And we would watch patients over and over again on ventilators who were dying in denial. And I just want to recognize that stress, and that stress is real. So that's not uncommon to see.
Joel, that's an excellent point. I'd like to piggyback on that. Yeah, I remember during the our second spike, and I'm spending December, January in the ICU with all these folks who didn't want the vaccine, and these beliefs that it gets complicated. And I wanted to follow up on, I'm actually looking at my slides for a presentation I'm giving later today on this subject. So Purvi, you asked, have any of us seen things like this? The answer is pretty much, if not every day, every week for sure. And so kind of my top 5 here. First, always give yourself grace. Joel speaks to that moral dilemma. You will see a lot of things that you would choose differently for yourself. Our goal isn't necessarily to convince someone to get from point A to point B. It's to meet them where they're at and do our best. My number 3 here. So my top 5 are: give yourself grace, set modest goals. Set modest goals might mean just getting invited back to a follow-up meeting. It may not get them to accept the chemotherapy today. Suspend judgment. And that's very hard for us to do. When you think about it, we are literally trained and paid for our judgment. And my kids about 10 years ago started saying, "Dad, don't be such a judger." And so that's my number 3. Let's us try to, when we're with families, again, try to meet them where they're at, enlighten them, make sure that they understand and can process since we suspend our judgment. And I think if you do that, again, your goal isn't necessarily to get them to a specific treatment. It's to make sure that within their understanding, that they're making the best decision possible, in line with their goals. And if the patient was talking about the toxicities and the complications that chemo can lead to, that's not completely unfounded. And so within that, it's probably not a choice that I would have made or you would have made or we would have made. But if you did your best to educate them, meet them where they're at, and support them, then that's the best you can do, and give yourself the grace, that you're going to see that a lot, and that will help kind of keep your bucket full on days when they're hard, when that's hard to do.
Corby did a great job because she, went in great detail with the patient about the risk and benefit of stabilizing her femur lesion, because it was already pathologically fractured and she was heading towards a massive impaction. And so she walked her through it very nicely. And I think we took her as far as we could go. And we respected her beliefs. And we even went on for the next two warm people to not be judgmental and to support them. Although I don't care if I ever see another ivermectin worm patient again.
Fair enough, for sure. I'm curious, roughly speaking, how much time did you spend with this patient and their family?
What do you think, Corby? 3 hours?
I would say several hours just over the course of like a week or a week and a half.
Yeah. And so don't discount that, where most of us, again, physicians in the healthcare system, 5 minutes or more is probably considered a long time, 3 hours. So again, you did a lot of good work here.
Yeah, Porvy saw her twice a day over her hospitalization, which was at least a week.
Yeah, I guarantee no one was giving them that much time elsewhere.
Yeah. Well, we have a tendency within our profession to sort of discount and dismiss patients that don't agree with us. And that is an unfortunate characteristic of some medical professionals. And so not discounting them, I think, is hugely important. And I think that, I was thinking back, I think Tim Ehrig did a lecture for us a few weeks ago, and I know one of the things that he is really good at with his patients, about in terms of the deeper dive, you're finding out what they're afraid of. What is it that what fears do you have, and that sometimes that can open some doors also. One of my curiosities, and when you talk about the importance of being non-judgmental, I've always tried to figure out creative ways to satisfy my own curiosity. Where did that come from? What made you think that, that was a good thing to do? I don't do it that way. I try to figure out some sort of more compassionate way to get to the. I don't know that, and that's really for my own education, my own edification, because what I recognize going in is that my likelihood of changing their mind is virtually nil. So how can I just really let them know that I'll walk with them, but I don't understand it. I'm really curious how you came to this particular conclusion, because it's certainly not consistent with anything that I've learned or seen before. So help me understand.
Yeah.
Go ahead, Gretchen.
I would say the biggest word that comes to my mind is curiosity, and that we come from a place of not trying to change minds, but being curious and understanding, getting to know that patient and family. And it may take several visits, like it did for you, just really investing in them as a person. And it's not that things need to be changed or decisions need to be made on one visit. I think that investment of curiosity and getting to know them pays off over time. And it's not in a care conference, and a lot of people, it's intimidating. I feel like a lot of these, especially if people feel judged, need to be a small group setting, slow paced and gradual.
Other thoughts? We're talking St. Louis, Phoenix. Do they live here or how'd they get connected with us or get connected with St. Louis in the first place?
They lived here.
Okay.
But she would go down there to travel
Gotcha.
and get treatment. And her children also live here.
Gotcha.
Her son was a flight attendant, and I think the original referral came through him.
Okay. I'm sure that it'll be very, very difficult to provide follow-up, but it sort of be interesting to know
Of course.
what happened.
She was a lovely woman and really educated, well established, and she was probably the most reasonable of her entire family. So Corby and I started this in the emergency room and followed her all the way through her surgery. So it was really, again, I applaud Corby. She never was judgmental, always supportive, and we wished her the best when she left for Arizona.
Yeah. All right. Any other closing comments or thoughts? Thanks for presenting that. I don't think we've ever had anything quite like that before, but it's an important thing because, as Jay noted, these are things that we face all the time, and it may not be, ivermectin and worms, but there's a lot of stuff out there, and it'll be really, really interesting to see over the next few years as the directives and the leadership of our national medical infrastructure seem to be undergoing some element of change under the new administration, how that's going to influence patient beliefs and requests and how we manage those in the months ahead too. So
Very diplomatically stated, John. Well done.
it is what it is. So.
Very diplomatic. Excellent.
All right. Okay. Hey, thanks everybody. We'll see you all next week.